Oh no, I know I have multiple sclerosis. I cannot tell you how many consults I get a week for people that think they have MS. It's a very legitimate fear. I would encourage you to go on the internet and type in any symptom. And any symptoms are always going to lead you back to MS, cancer, Lou Gehrig's disease. Those are to be the main three. So if you look up any symptom and keep looking, it's going to take you back to MS. MS is a very difficult disease to diagnose prior to MRI, and it's become much easier since then. So what is multiple sclerosis? Multiple sclerosis is an autoimmune mediated inflammatory disease that attacks the myelinated axons in the central nervous system. It's interesting, and I really haven't been able to really confirm the story, but 30, 40 years ago, there was an island somewhere in the South Pacific, and everybody got MS, and they went down there was just nasty pigeons just everywhere, and they killed all the pigeons. And over time, this MS just sort of went away, and so they gathered all these pigeon droppings thinking they would find a vector. Normally, if you find a vector for disease, you're able to find a cure, but nothing ever became of that. But we've always thought that it was something in the environment. It was an autoimmune disease. The average age of a person that gets MS is about 30. So it's a young person's disease. And I often say if I can get people to 50 with minimal disability, they generally do well because MS starts burning itself out as you get a little older. 70% are diagnosed between 20 and 40. It's much more common in women than men, like 3 times more common. But the disease is much worse in men. The goal is to make a correct diagnosis and rule out all the different mimics that look like MS, but they're not, and then recommend the disease-modifying treatments. I never forget, like in 1991 when the first MS drug came out, there was a lottery, and I remember put everybody in the lottery. None of my patients got it, and how terrifying that was. But one of my patients, terrible disease burden. She got beta-seron pretty quickly, and I just talked to her on the phone last week. I'm in a different city now, but talked to her on the phone, and she's just really done great on the disease-modifying treatments, and we're going to talk about that later, but it's very, very complicated. Symptoms are just so widely variable, it's not even funny. You can have almost any symptom and come down with MS. So starting at the top, you can be dizzy, you can have blurred vision. One of the most classic symptoms we hear is someone has optic neuritis. They'll feel a shade come down over their eye and go blind in one eye, usually a very young woman. And that's the first sign of MS in some young women. Get numbness on one side of your face, dizziness, lightheadedness, just tingling paresthesias. Any of the cranial nerve defects, you get double vision, this optic neuritis, trigeminal neuralgia, Bell's palsy. They also can just get cognitive impairment. As you move down, you get numbness across the chest. You just don't see that with neuropathy. A lot of people feel like a band, across their chest or around their belly button. It's like someone would have a straitjacket on them. As it gets further along, they can get bowel and bladder dysfunction. And it's just one of these kind of diseases, if you mention all those symptoms, we all go, well, I've had that before, but it doesn't mean you've had MS. There's subtypes. You get relapsing remitting MS, and then relapsing remitting MS with secondary progression, primary progressive MS. One of the things we're facing a lot, because we do MRIs just all the time, people with headaches and just dizziness, everything, is you can get a radiographically isolated syndrome. They're typical MS lesions on MRI, but they've never had any symptoms, no neurological disease. So we follow those patients, and about 35% of them will develop a clinical event of MS within 5 years, 80% within 15 years. So they need to be followed very closely. So how do you make the diagnosis? Well, we have all these criteria, but it's just so much easier when the MRI is positive. They have to have over 2 clinical attacks with objective evidence of 2 lesions. And if you have that, you have no other, you need nothing else for the diagnosis. We used to say 2 lesions separated in time and space. So you have that same lady that has the optic neuritis when she's 20 and then comes back when she's 27 with a numbness on the right side of her body. So there's a lot of different criteria. We could go through these specifically, but I think it just gets too complicated for a video like this. So what do we do workup-wise? We do an MRI of the brain. We do an MRI of the cervical spine. Sometimes we don't see a lot in the brain or can be confusing, and they'll have a plaque in their cervical spine. And then decide if we need to have a lumbar puncture. A lot of times I don't do lumbar punctures anymore if I already know the diagnosis based on MRI. But they can have, elevated IgG, oligoclonal bands, which are sort of an aggregate of IgG. Just 2 or more CSS-specific oligoclonal bands can fulfill the requirement for additional information for MS. You got to exclude all the mimics, and we see so many of these. Most of the time when I work people up with MS, they don't have it. The first would be cerebral vascular disease. And most of the MRIs I get referred to me for MS have cerebral vascular disease. Lyme's disease can look like this: HIV, syphilis, TB, any viral infections. You got to make sure they don't have a glioma. I get people sent for MS and it's actually a tumor. Lupus, sarcoidosis, vasculitis, nutritional deficiencies like B12, folate, copper. So work up MRI of the brain with that contrast, MRI of the cervical spine. Consider battery evoked potentials. We just don't have access to that much anymore. Insurance doesn't pay for it. The equipment's very expensive. It's great to get a visual evoked response. And then lumbar puncture, spinal fluid evaluation. So if you think you have MS, I think the starting point is to see your doctor and get an MRI of the brain, and then decide if you need an MRI of the cervical spine. That's the first thing we do. And then talk about disease-modifying treatments. We're going to talk in another video about that. So what I'm going to do next is I'm going to put up a bunch of MRIs. I'm going to do a video on the MRI of multiple sclerosis. It's going to be very fascinating, particularly if you have MS. We're going to talk about a bunch of different patients and what their MRIs look for, because that's the starting point for me with most patients. If I think they have MS, I do an MRI of the brain. So this is Dr. Caudle Miller, the Brain Doctor. Like, comment, subscribe to my channel. I answer every comment within a few days, more later.